Hi, I'm Dr. John Michael Lau, and I'm going to lecture on the heart for our refreshers. So, we have this overview. We will talk about ischemic heart disease, rheumatic fever, um, other forms of endocarditis, valvular heart diseases, congenital heart diseases, diseases of the myocardium, diseases of the pericardium, the tumors of the heart, congestive heart failure, and hypertrophy of the heart. So before we start with ischemic heart disease, let me just give you a prelude on atherosclerosis. The process of atherosclerosis always starts with endothelial injury. The damaged endothelium or endothelial dysfunction allows it to be very permeable and very thrombogenic, thereby inviting different substances into the endothelium, such as the lipoproteins, the low density lipoproteins, in which after which the macrophages eat them, and these macrophages transform into foam cells. Okay. After that, you have smooth muscle cell migration that will lock in the atheroma and become a plaque. And soon later, when it ruptures, it becomes it invites thrombosis, invites platelets, so that a thrombus is formed. And much later, one of the fates of thrombosis is embolism. And there are other complications of thrombosis as well. Okay, so next. So ischemic heart disease is the interruption of blood flow into the myocardium. The most common cause is atherosclerosis that is leading to thrombosis. Okay, and clinical manifestations, it can be silent. It can present as a chest pain or angina pectoris, myocardial infarction, and chronic ischemic heart disease. And it is aggravated by metabolic syndrome. As we know, metabolic syndrome is composed of hyperglycemia, hypertension, dyslipidemia, and obesity, which is pro-inflammatory. Angina pectoris are three kinds. You have stable angina pectoris, stable angina. You have unstable angina. So stable angina is chest pain upon exertion. Unstable angina is chest pain even at rest. Okay. Prinzmetal angina is chest pain brought about by vasospasm. Next is myocardial infarction. It is the resultant coagulative necrosis on the myocardium because of a blockage of the blood flow. And you have two patterns. You have transmural, wherein it is caused by a total blockade of a coronary artery, or subendocardial, wherein only the inner one-third of the myocardium is affected because of a partial blockade of the coronary artery. So transmural infarction equates to an ST elevation. Subendocardial infarction equates to a non-ST elevation. Complications. You have number one complication of myocardial infarction is arrhythmia. You have heart failure, rupture of the myocardium, rupture of the papillary muscle, thrombosis, okay, and ventricular aneurysm. Okay. So this is the flow chart from coronary artery disease leading to myocardial infarction. And ultimately you have heart failure, then death of the heart. Okay. So it is nice to note that sudden cardiac death is not really how do you say this, preceded by myocardial infarction. In fact, majority of cases of sudden cardiac death is from cases of myocardial ischemia. Myocardial ischemia that is undergoing arrhythmia. Majority of these cases lead to sudden cardiac death. And we have This is the timeline of the gross and histologic changes of myocardial infarction. Okay, take note that grossly, earlier we have a mottling, no, a gray mottling. Okay, I have another slide for um, this aspect of the lecture. So here we have, no, it's not dark mottling. It's not gray mottling. It's dark mottling. Okay, and much later, the area of infarct regains its blood flow. That's why it is hyperemic with hyperemia. However, the area that has been has undergone necrosis will remain as is yellow, soft, caseous. No, it's not caseous. It's yellow brown softening. No, centrally yellow brown softening. And much later, it will be covered with a scar, fibrous tissue, fibrin. Okay. Initially, you have wavy myocardial fibers. Okay, and you have and and it ends into formation of a scar. Okay, so you can always go back to this. Take note of the timeline. And how is myocardial infarction diagnosed by the help of biomarkers? Okay, we have actually in this slide we only have two, but we also have another one, which is myoglobin. Okay, um, here in this slide we have CKMB and troponin. These are enzymes that are liberated by the necrotic cardiac tissue. Okay, so we mentioned about they rise almost at the same time. However, the persistence of the troponin makes it different from CKMB. Okay, so CKMB, it rises like more or less 3 hours. 3 hours. Okay, here it's written 6 hours. Okay, and it goes down after probably goes back to normal after 2 to 3 days. Okay, however, for troponin, rises much the same, 3 hours, then goes back to normal after 2 weeks. So, which makes troponin as the most specific marker for myocardial infarction. For CKMB, it is useful because it will indicate it is a marker for a possible, if there is a possible reinfarction, CKMB will rise again within the will rise again, no, within this slope, no. So CKMB will tell us about reinfarction. Okay, myoglobin. Myoglobin is we mentioned myoglobin a while ago. Myoglobin is a marker again, okay, that easily rises as early as I think it's 1 hour after cardiac injury, and it goes down back to normal after 1 day. It is the most sensitive marker for myocardial infarction. And these are the complications of myocardial infarction. Okay, can always go through this. So take note that we have two types of pericarditis. We have peri-infarction pericarditis. We also have post-infarction pericarditis, which is called Dressler syndrome. And in between, we have rupture of the different types of muscles, no? Be it the myocardium, be it the ventricle, be it the papillary muscle. Okay, you can always review on that. Next is rheumatic fever or rheumatic heart disease. Rheumatic heart disease is a multi-systemic inflammatory disorder. Okay, and it involves children, young children that have this um, streptococcal infection on their throat, no, causing pharyngitis. Okay, and the etiology is immunologic, no, it is autoimmune, okay, in such a way that the body develops antibodies against the streptococcal antigen, specifically the M protein, okay. And for histologically, we can see Ascoff bodies, no, these are likened to a granuloma, okay. These are focal interstitial myocardial myocardial inflammation. And the anistose cells are very much likened to the multi-nucleated giant cells in tuberculosis. Okay, so this Ascoff body attacks the all layers of the heart. You have the causing pericarditis, myocarditis, endocarditis. Okay, and it causes also causes stenosis of the mitral valve. Okay, particularly it's seen as a fish mouth stenosis. Okay, for endocarditis we have vegetation, no, vegetations on the valves, the lines of valve closure. Okay, the vegetations, by the way, are non-friable. That means they are not broken in and released into the bloodstream as emboli. No, they stay as into the area where it is formed. Okay, and the other manifestations such as fever, joint pains, subcutaneous nodules, and Sydenham's chorea are just the reaction of the body towards the streptococcal antigen. No? It's autoimmune. Okay, and we will find it discover later in another disease. Okay, wherein we have a friable or embolic vegetation. Okay, so next, what's the acronym for this? What are the symptoms of rheumatic heart disease? You have joint pains, letter J. O presents stands for carditis. N, nodes, no, subcutaneous nodules. E, erythema marginatum. Okay, S is Sydenham's chorea. This involuntary movements, no. Another type of endocarditis is infective endocarditis. It is caused by a bacterial or fungal infection elsewhere that lodges into the valves, no, of the heart. It is a friable vegetation. Friable, that means that these are embolic. Moves into the different blood vessels, smaller blood vessels, causing thrombosis, causing clots. Okay? And the cause of it, most common cause is the Staphylococcus aureus. However, for subacute or pre-existing, no, the cause is Streptococcus viridans. The most common valve that is involved is mitral. However, if it involves an IV drug user, the most common valve involved is the tricuspid valve. So what are the complications? Valve, you have vegetations on the valve, ulcerations, cord rupture, embolization leading to, since it is infectious, septic infarcts, and post-streptococcal glomerulonephritis. What are the clinical manifestations? You have fever, rot spots, okay, in the retina. Osler nodes, these are painful nodes in the soles of the palms and feet. Murmurs, Janeway lesions, these are painless lesions on the soles and feet. Anemia, nail bed splinter hemorrhages here, okay, and emboli. Okay. Next is the marantic endocarditis or the non-bacterial thrombotic endocarditis. It is non-bacterial, that means it doesn't cause fever, the vegetations are sterile, okay, and although embolic, okay, and it is very common among these disorders or diseases that present with wasting, such as cancer or malnutrition. Okay, next is Liebman-Sachs endocarditis. Just remember, it is endocarditis presented in SLE, no, systemic lupus erythematosus. Then it presents with small vegetations. Carcinoid endocarditis. It is caused by a carcinoid tumor elsewhere in the GI tract that is affecting the valves. No, so these carcinoid tumor release serotonin products, no, or carcinoid products that are lodged into the tricuspid valve and the pulmonic valve. No, usually the right side. Why? Because when it passes through the lungs, no, the lungs wash out the carcinoid product and doesn't and reduces the effect of it on the left-sided valves. These are the endocarditis, no, that are mentioned a while ago, and just take note that it's the marantic endocarditis and the rheumatic endocarditis, rheumatic heart disease, that are non-destructive, okay, non-destructive, and this infectious endocarditis and the Liebman-Sachs are the destructive ones. And take note of the size. You have small warty. If it's big already, then it's either this one, infective endocarditis, or this one, marantic endocarditis. This slide, this is still under valvular disease. No, a while ago we were talking about valvular disease basing on etiology or the cause. Okay, now we talk about valvular heart diseases, with which it talks about the effects on the valve itself. No, so for example, whatever the etiologic agent, it can have mitral stenosis, regurgitation, or a prolapse. No, so those three. No, so you can just review on them. So for example, for mitral valve prolapse is very common in cases of Marfan syndrome, no, wherein there is a myxoid degeneration leading to the prolapse of the mitral valve into the previous chamber, or the atrium, no, or the left atrium. Okay, so there, no, mitral stenosis is very common in rheumatic heart diseases. What else? For the tricuspid valve, so again, rheumatic heart disease. We mentioned about in infective endocarditis among IV drug users. Okay, it involves the tricuspid valve. For pulmonic valve, so in tetralogy of Fallot, take note that in tetralogy of Fallot, one of the components is pulmonic stenosis. Okay, for aortic valve, it's very common for calcific, no, aortic stenosis due to aging. Okay, and other abnormalities as well, no, even abnormalities in the valve due to prosthesis, no, so whether it's wear and tear, bacterial infection, thrombus, no, a thrombus formation, or anemia due to hemolysis, no, because of this prosthetic valve, red blood cells are being chopped down, and it's called wearing blender effect. Congenital heart diseases, so usually they are unknown in etiology. There's no really known cause. However, there are several associated. No, these are several of these congenital heart diseases are associated with several chromosomal abnormalities. So for example, Turner syndrome, it's associated with coarctation of aorta. Down syndrome, it's the either atrial or ventricular septal defect. When living in higher altitudes, or in the mountains have risk for patent ductus arteriosus and for rubella infection. Okay, generally measles. Okay, it's German measles that cause any that will lead to any type of congenital heart disease. And even tetralogy of Fallot has this familial predisposition. Okay, so we have two types of congenital heart disease. It's non-cyanotic or late cyanotic and cyanotic. So we'll use the next slide. Okay, so congenital heart diseases, okay, can be either there's a hole in the septum or there's a constriction causing obstruction of the blood flow. So take note that just for your mnemonic, for shunts that travel from left to right, just remember D, and the examples are VSD, ASD, PDA. For right to left shunt, remember letter T. Tetralogy of Fallot, TOF, and what else? The transposition of the great arteries. For this constriction, remember CSA. CSA. So CSA is this one. C is coarctation. Okay. S is stenosis. A is atresia. So for left to right shunting or late cyanosis or non-cyanotic, we have three examples: ASD, VSD, and PDA. The most common type of ASD is this ostium secundum, okay, and it's most commonly found in adults. And for all types of shunting, left to right shunting, we have paradoxical emboli. In VSD, it's most common among children, and the most common type is membranous. For PDA, patent ductus arteriosus, which presents as with machinery murmur, you have failure of the closure of the ligamentum arteriosum, thereby it's called patent ductus arteriosus. Indomethacin closes this one, but prostaglandin opens it. No? All of this will lead to Eisenmenger syndrome. Eisenmenger syndrome is the uncorrected left to right shunting that it will eventually become a right to left shunt, leading to late clubbing, late polycythemia. Next is right to left shunting. So early cyanosis. Why is it early cyanosis? Because unoxygenated blood is allowed to travel into the circulation, no? Systemic circulation. Okay. So next, first is this tetralogy of Fallot. Tetralogy of Fallot is composed of PROV, pulmonic stenosis, right ventricular hypertrophy, overriding aorta, and ventricular septal defect. It's the most common cyanotic, and it's boot-shaped. Okay, for transposition of great vessels. Okay, so you have the first type is with VSD. Okay, wherein we need VSD so that the blood gets oxygenated. Okay, and if there's no VSD, we need PDA for the oxygenation of the blood. Next is obstructive lesions. Okay, so this one is coarctation of aorta. So we have preductal or the infantile coarctation of aorta. This is associated with Turner syndrome, where we have left extremity cyanosis. Next is we have the postductal. Okay, the preductal, by the way, has this PDA, no, the patent ductus arteriosus. Take note that the flow of the PDA is from what? It's from right to left. Okay, take note that in the isolated PDA, it's left to right, right? But in this PDA type of PDA, it is right to left. So here, for the second type is the adult or the postductal type. Okay, so it has no PDA. Okay, and you have upper extremity hypertension, lower extremity hypotension, and rib notching. Okay. So next is diseases of myocardium. So first is cardiomyopathy. Cardiomyopathy, these are diseases of the heart muscle that are non-inflammatory and is not associated with hypertension, congenital heart disease, valvular heart disease, and coronary artery disease. No? Majority or the mainly the cause of this is genetic. Okay, genetic. So for example, the first type is dilated cardiomyopathy. Okay, it is secondary to a problem in the dystrophin gene. Okay, leading to a dilation of all the chambers, all the ventricular and atrial walls. Okay. However, it's also related to alcoholism. Okay, thiamine deficiency, prior myocarditis, and pregnancy. It's the most common cardiomyopathy. Next is hypertrophic cardiomyopathy. Again, it's genetic, and you have a mutation in the myosin gene. Okay. Here, you have hypertrophy of the chamber of the ventricular walls, such that it leads to asymmetrical septal hypertrophy. Okay, and because of this obstruction, the heart is not able to relax. No, the hypertrophic myocardium, the heart is not able to relax. It's called diastolic dysfunction. It leads to syncope and death of usually athletes. Restrictive, take note, there is an infiltration of a substance called amyloidosis that leads to stiffening. Okay, we also have a special type of dilated cardiomyopathy, which is called arrhythmogenic right ventricular dilated cardiomyopathy, in which there is a fat replacement, and we have arrhythmias and sudden death also found in athletes. So take note that in dilated cardiomyopathy, it is a systolic dysfunction. Hypertrophic cardiomyopathy, it is a diastolic dysfunction. Restrictive cardiomyopathy, it is a diastolic dysfunction. The next kind of disease of the myocardium is myocarditis. It is the inflammation of the myocardium brought about usually by infection, usually viral, Coxsackie virus. However, if it's due to a parasite or a Trypanosoma cruzi, so it's parasitic. No? So there is inflammation, there is infiltration of inflammatory cells without any ischemic heart disease, valvular heart disease, rheumatic cause, or congenital heart disease. Okay, so let's go back to cardiomyopathy. So for dilated cardiomyopathy, all chambers are dilated. For hypertrophic cardiomyopathy, you have thickening. So for dilated cardiomyopathy, you also have hypertrophy. Okay, however, the more prominent feature is the dilation of the chambers. For hypertrophic cardiomyopathy, the more prominent feature is the thickening of the ventricles. Okay, take note that you have asymmetrical septal hypertrophy. It's a banana-like configuration. There is left ventricular outflow obstruction. For restrictive cardiomyopathy, you have invasion of usually amyloid, and it appears as an apple green birefringence on polarized light. um, there's a special type of cardiomyopathy, uh, and it's called Takotsubo cardiomyopathy. It's otherwise known as broken heart syndrome, wherein there is ventricular apical ballooning due to increased sympathetic stimulation. No? So overwhelming sadness can lead to um, rupture of the uh, chordae, no? Chordae tendineae. Okay, so this is what I mentioned about, no. So for dilated, majority is genetic. Even for hypertrophic, 100% is genetic. Uh, okay, so yeah. So next is the genes involved, no. So take note that in dilated cardiomyopathy, it's the dystrophin and the other genes that start with letter D. And for hypertrophic cardiomyopathy, we have myosin, the genes that start with M. Okay, and the ones in green are combination of both, no, hypertrophic and dilated. So okay, so all will lead to heart failure, no. Diseases of the pericardium. Okay, it's classified as either non-inflammatory, you have, or inflammatory. So under inflammatory, it's acute or chronic. Okay, so for non-inflammatory, it's secondary. If it presents with hydropericardium, it's secondary to a underlying edema, and the most common cause is the congestive heart failure. Secondary is hypoproteinemia. For hemopericardium, the most common cause is trauma, and secondarily is the myocardial rupture. For acute pericarditis, usually it's classified into serous. Okay, when it's serous, you have an exudate that is protein rich but clear. Okay, and it's caused usually by these, no, SLE, rheumatic heart disease, viral infections. However, when there is serofibrinous pericarditis, it's secondary to uremia, MI, and rheumatic heart disease. When it's purulent or cloudy exudate, it's secondary to bacterial infections. For hemorrhagic pericarditis, it is secondary to TB, okay, or a tumor. You have a bloody exudate. For chronic pericarditis, it's either caused by TB or staph, okay, and it presents like rheumatic heart disease. No, you have a thickened, scarred pericardium, fibrous proliferation, and calcification. Remember that in rheumatic heart disease, you have pancarditis, no? Wherein there is pericarditis, myocarditis, and endocarditis. Tumors of the heart. So most common tumor of the heart is metastatic, no? Metastatic. Most common coming from the lungs. However, if it's primary, the most common type is myxoma, which is a benign primary tumor. It's found in adults. In rhabdomyosarcoma, it's found in infants. So myxoma is commonly found in the atrium, left atrium. Rhabdomyoma, it's found more in the ventricle. So it's associated with tuberous sclerosis. Angiosarcoma is a malignant, most common primary malignant. Okay, but in relation to metastatic carcinomas, these primary carcinoma of the heart, they are rare compared to metastatic forms. Congestive heart failure is the inability of the heart to pump. Okay, so we have one marker here called the brain natriuretic peptide. It is increased in cases of congestive heart failure because brain natriuretic peptide the role of brain natriuretic peptide is to diurese, to excrete, no, excess sodium. Okay, and it's used to rule out other differential diagnosis of congestive heart failure such as asthma, COPD, pulmonary embolism, or even ACS, no, what do you call this, coronary syndrome, acute coronary syndrome. So we have two types of congestive heart failure. So because the first type is what happens first, no, it's the left-sided congestive left-sided heart failure, no. The most common cause of which is hypertension, no? That leads to ischemic heart disease. Okay, so um, the manifestations. So for congestive heart failure, the manifestations are really due to the pooling of blood to the previous chamber. So for example, what's the previous chamber or part, no, before the left side of the heart? That is the lungs. So you have pooling. So since the left side of the heart is not able to pump anymore, you have pooling into the previous chamber, which is the lungs. So you have pulmonary symptoms such as dyspnea, orthopnea, pleural effusion, uh, also reduction in renal perfusion, and cerebral anoxia. But take note of this too. Okay, all, even cough. Okay, it's a manifestation of congestive heart failure. Next, in the long run, left-sided heart failure will lead to right-sided heart failure. In fact, left-sided heart failure is the most common cause of right-sided heart failure. And the symptoms of right-sided heart failure. So when the right side of the heart doesn't pump anymore, there is a pooling of blood into the previous chamber, which is the systemic circulation. So the symptoms are systemic, such as peripheral edema, ascites, pleural effusion, peripheral edema, hepatosplenomegaly, and congestion, and neck vein distension. Okay. Okay, so next, what else? There's another type of right-sided heart failure which is isolated. This is what we call as the cor pulmonale, no? Or the isolated right-sided heart failure. It is due to pulmonary hypertension because of underlying pulmonary problems, no? Such as COPD, such as a problem in the, for example, there is a problem in the circulation in the pulmonary arteries. Okay, that will lead to cor pulmonale. But the symptoms are also the same. Okay, systemic. So left-sided pulmonary, right-sided systemic. Next is hypertrophy of the heart. No, so very much the same as heart failure. The left ventricle becomes hypertrophied, or the left side of the heart becomes hypertrophied because of systemic hypertension. Okay. Another cause is valvular heart disease, no, on the left side. Okay. However, in the long run, this left side of the heart, because of too much pressure, it doesn't anymore carry the cardiac load. Okay, it fills, and it leads to hypertrophy of the right side of the heart. In fact, the most common cause of right ventricular hypertrophy is left-sided heart failure. Okay, other causes are valvular disease, valvular diseases, congenital heart diseases, left to right congenital heart shunting. Okay, and this condition also, isolated heart failure, isolated right-sided heart failure, cor pulmonale, no, is also mentioned. It's due to pulmonary hypertension due to COPD or any other cause of any other problem in the lungs, be it in the lung parenchyma or in the circulation, pulmonary circulation, that will ultimately lead to pulmonary hypertension, will lead to cor pulmonale, isolated right-sided heart failure. Okay, so take note that in the left side you have the left ventricular hypertrophy. Okay, take note that in left-sided hypertensive heart or hypertrophied heart, no, you have concentric thickening. Okay, compared to the compared to the hypertrophic cardiomyopathy, it's a asymmetric septal hypertrophy. For right-sided hypertrophy or right-sided hypertensive heart, okay, here the right side of the ventricle is hypertrophied. Okay, so this is a diagram, a flow chart that will interrelate, interrelate different factors, be it hypertension, valvular disease, even myocardial infarction, that will lead to increased cardiac load, that will lead to hypertrophy, and eventually, later, if not overcome, will lead to heart failure. So we already talked about the ischemic heart diseases, myocardial infarction, timeline of myocardial infarction, complications of myocardial infarction, what are the enzymes in myocardial infarction, rheumatic heart disease. We mentioned about the manifestations, Jones. We mentioned about Ascough body. We mentioned about the etiology. It's autoimmune. Other forms of endocarditis, infectious, bacterial, Staph aureus, what do you call this? What else? For IV drug users, okay? We also have IV drug users affects tricuspid valve instead of mitral valve. We mentioned about carcinoid tumors, okay? Carcinoid heart disease. Another is the marantic endocarditis, okay? Another is the LSE, Liebman-Sachs endocarditis, valvular heart diseases. These are just effects of the endocarditis that we have mentioned previously. These are anatomic. No? For congenital heart diseases, we have cyanotic and acyanotic, non-cyanotic. Okay, take note of the blood flow. Take note of the cardiac diseases that congenital heart diseases that are associated with some chromosomal abnormalities. Diseases of the myocardium, it's cardiomyopathy. We have dilated, hypertrophic. We have restrictive. We also have this arrhythmogenic. Okay. Diseases of the pericardium, we have non-inflammatory and the inflammatory, acute and chronic. Tumors of the heart, take note of metastatic, myxoma, okay. Congestive heart failure, either left or right. Left-sided heart failure and left-sided heart failure lead to pulmonary symptoms. Right-sided heart failure, systemic symptoms. And the same goes for the hypertrophy of the heart. So thank you so much, and I think we have basically reviewed on the cardiac pathology, and let's now go back to our study. So don't forget to practice answering sample exams. See you.